Good afternoon. I welcome you all on behalf of Orthopedics Trauma Center for this CGR on establishment of fragility fracture liaison services at Trauma Center. So, a little brief about as the longevity of people is increasing in India with better healthcare facilities, we are getting more of geriatric patients. I remember when we were in training for a post graduation, we didn't have that many of elderly patients coming to as fractures or to trauma center. But actually, at that time, there used to be no different, dedicated trauma centers. But with time, with increase in longevity, with increase in better healthcare, we have more proportion of elderly people who are going to survive to a greater age, and so hence they are going to naturally develop osteoporosis and come to trauma center and other medical care facilities, not just across India but across the world, with more hip fractures and other fragility fractures. So it's very important that not just from orthopedic point of view, orthopedics is involved in caring, the treating the fracture, but as such, in overall improving the quality of life and to provide a wholesome treatment as well as to increase the longevity, reduce the morbidity and reduce the mortality, as well as to give them a better quality of life. It is important that we should have a sort of amalgamation of all the possible services, including orthopedics, geriatric medicine, physiotherapy, nursing services. We don't have such home care centers in India which dedicated, like in the Western world, dedicated to the care of elderly people. But maybe with time, we'll have establishment of home care centers for elderly, and the community nurses who will go and coordinate their all the needs which are there for elderly. But this particular thing, the fragility fracture, is focused only on orthopedics part of it, but not just the fracture part, but the wholesome, nutrition, mobilization, physiotherapy, how to be able to get them back to the pre-injury status. So with that introduction, I would request orthopedics department at trauma center to present this CGR on how to establish fragility fracture liaison services.
Good afternoon. Let's begin with we can review our knowledge. Fragility fracture is an adulthood fracture due to trauma less than or equal to fall from standing height, like except finger, toes, and face and skull. And the most common fracture is vertebral fractures. It's account for around 40% as per the study conducted by Lancet. And other fractures are hip fractures, distal radius fracture, and proximal humerus and pelvis fractures. It's a osteoporosis is a loss of bone mass and bone microarchitecture. We can see the slide, the picture which showing bone microarchitecture changes as comparing with a normal healthy bone. First one is the healthy bone, then we get a less trabecula in osteoporosis, and severe or osteoporosis again bone become much more weak. Even trivial trauma which lead to the fracture. We can revise the definition: a disease characterized by low bone mass and microarchitecture deterioration of bone tissue, leading to enhanced bone fragility and a consequent increase in fracture risk. It's most prevalent in post-menopausal women and elderly individuals which age more than 50, and these impact lead to decreased quality of life and increased healthcare cost. The prevalence of osteoporosis in women has been reported to be 23.1, and in men it is 11.7%. We can see 1 in 3 women after the age of 50 will experience osteoporotic fracture. Similarly, in men also 1 in 5, it's almost 20%. If you take in this room, 1 in 3 of women may develop osteoporotic fracture with after 50. Even 20% of also, even if we also related to in our family also there are old age person will be there, so there are high chances, 1 in 3 chances of osteoporotic fracture it's a silent disease. Even we can go for the based on the world population, 750 million may be affected globally. It means 10% of all population will affect osteoporotic fracture. And then regarding the Asia, this is a study conducted by the Asia Pacific Regional Audit, conducted by International Osteoporosis Foundation, that look for the epidemiology, cost, burden of osteoporosis, and the data taken in 2013. Then they predict the fracture osteoporotic related complication 2050. It is conducted in 16 countries, South Asia country. They are mentioned that 50% of total hip fracture will occur in Asia Pacific region. The remaining 50 only the remaining world. So majority is focused on the Asia Pacific area. Unfortunately, we are also in this category. Oh, as per their prediction, overall population growth will be 25% between 2013 to 2050. In this case, the population with age more than 50 years increased by 144% by 2050. That means there is high chances of population with the age more than 50. Then its incidence of osteoporotic fracture will also increase in future. So it's a reminder call for us. Similarly, we can see age over 50 increased from 120 million to 620 million, especially in India. In India is the highest percentage of increasing the population with age more than 50 at 2050. So in the world, it's higher in the Asia Pacific area. In the Asia Pacific area, India is the highest number of person with age more than 50 in next to 2050. So we thought that whether it is a third call for us, because in 2019 the same audit predicted that it is estimated that 2030 the number of people in India with osteoporosis will reach to 36 million. What happened in 2013? It is 50 million. They predicted 36. In our the real situation, it come up to more than 14 million. If they are predicting in 620 million, it will be higher than that of what we are expecting. As per their projection, it's like 1.8 million population will be in our next 2050 in India, and the life expectancy also will increase from 67 to 77, which due to increased healthcare facilities and lifestyle changes. So we have to expect more osteoporotic fracture because of our exceeding our life expectancy. This is another study conducted at AIIMS Trauma Center, in which they check for the injury mechanism of hip fracture in India. In this, fall from standing height is maximum 76%. So in hip fracture, the most common injury mechanism is fall from standing height, which means osteoporotic fractures. The another study conducted 3 different centers at Delhi, including AIIMS, management of older adults with hip fracture in India. In this also, all the fracture which got admitted in the hospital is the same mechanism of trauma, fall from standing height. Then why India is high prone to fragility fractures? The reason behind is Indian population consumes much lower amount of calcium, and more than 80% urban Indians have serum vitamin D level below 20 nanogram per ml. And the same time, even though it's a big problem, even though in our national health priority, osteoporosis not designated as a national health priority, lower awareness, especially in urban area, only 10 to 50% population are familiar with osteoporosis. The growing burden of osteoporosis fracture in India is due to increased number of elderly people at risk, high rates of vitamin D deficiency, and a lack of epidemiological and economic data. Then why is the need? If we go for retrospective data, and then we can found that we need to improvement in our system. because in the previously it's the lack of organization because of fragmented evaluation and treatment process, high attrition rate more than 80%, and poor documentation. Now I invite you to continue, Dr. Vithi, for further.
Thank you, Dr. Babu. So I'd like to start off by asking what are the challenges the patients have. So why are we starting this particular liaison system for a patient who is having an elderly patient with fragility fracture? There is a delay in diagnosis for osteoporosis for a lot of patients. Majority of them, it may have been missed. It gets delayed for whatever reasons. They have multiple comorbidities as age increases, non-communicable diseases increases like heart disease, diabetes, and they end up having to take multiple medications. And all of these things are actually a burden on the elderly patients. And a fall as such and a fracture, if not appropriately managed with an early intervention from multiple teams, can create anxiety and depression for the patient, which actually impedes their mobility further. Now, what are the surgical challenges that we are facing? When the hip fracture present to us in emergency, the patients having multiple comorbidities, we have to send multiple referrals to get clearances. That further causes delay, and a delay can also cause the patient to be bedridden, causing further complications to get the surgery done and for the patient's recovery. Say a patient did get all of this, and in an earlier system and we could not get this easily done, patient had to go to multiple departments. Say the patient is chargeable, they go to multiple departments, the appointments are scattered, there is delay. In such a scenario like AIIMS, there is a significant delay, even though just because of the patient load. There is a significant delay for any patient in the government sector without a unified scenario to have all these appointments done, all these tests done, multiple home visits, multiple hospital visits, long waiting time for an appointment day. All of this causes delay for the patient and further causes the patient to have impedance of their confidence, may cause complications like having chest infections other than the fracture itself, which causes morbidity and mortality to the patient, and it's further burden on the entire health system or the hospital itself. And these patients require a helping hand for mobility assistance, not just as a walking aid, but also for their morale. Now, we are talking about the same thing, and multidisciplinary care is very important, and recognizing that an integrated approach, which is essential, has made us reach a point where we have decided that a fracture liaison system will be helpful for the patient to manage not just the fracture, but the things associated with it, which causes the patient to have delay in treatment and a delay in mobility. Okay. So this is the watershed moment. So what is this FLS that I'm talking about? It is a coordinated model which guides the patient through the osteoporosis management after a fragility fracture, which helps to prevent further fracture. Imagine a patient having one fracture, she does not know that her nutrition was the problem, her anemia was not treated properly, the lighting condition in her house was not the problem that was treated properly. Something as simple as slipping and falling in the washroom, a rod which is 300 rupees would have helped her avoid another hip fracture, another hospital visit. So all of these things we might be aware, but all these patients might not be. And we are not entirely sure how well we are reaching the patient with this information. So such things has to be understood. So FFLS is again a multidisciplinary approach which includes orthopedicians, anesthetists, dietitian, physiotherapist, social worker, and multimodality approach which helps the patient to rehabilitate and recoup for their life after the visit to hospital. So what is fragility fracture liaison service proposal that is being undertaken by us? So like I explained, FLS, like just like diabetes or any non-communicable disease for elderly patient, this osteoporosis is a silent disease that has been there, which is unrecognized. Patients fall in their house and they have fractures. These are preventable fractures to an extent, and a recurrence is definitely preventable, and there is a high risk for second fragility fracture for 86% of the patients, maybe because of lack of care and maybe because of underdiagnosis and undertreatment. So the goals and objectives is to establish a fracture fragility liaison service, give anti-osteoporosis management, develop guidelines for prevention of fragility fractures, determine the magnitude of secondary fragility fractures, maybe despite the intervention or without the intervention, and target is to have just one visit. If the patient had one fragility fracture, we prevent a second visit for the patient and the family. So it's an ICMR funded study which includes 3 centers, which is AIIMS New Delhi, AIIMS Jodhpur, which is yet to be started, which will be starting in a couple of weeks, almost beginning of next month, AIIMS Rishikesh. And the plan is to enroll around 1,500 patients. And I'm happy to say that we have almost reached 1/3 of the target already. And the study duration, even though it's 3 years, and it has already started in September 2023, and we are able to already take in 1/3 of the patients, which says a lot. So the inclusion criteria is any patient above 50 years and any fragility fracture from low energy fall, which is fall from standing action. Pardon me. The exclusion criteria is if the patient is not giving consent for participating in the study, and pathological fracture and any periprosthetic fractures. So what is the core of the FFLS program? Obviously the orthopedician, and other than that, it is a team that is the whole point here. It consists of nurse coordinator. It consists of a geriatrician. It consists of a physiotherapist, a social worker, and a dietitian. Now, what is the function of a nurse coordinator? They are actually the initial point of contact after the search, after the patient comes to us. They are critical to ensure that patients are enrolled, patients are following up, identifying that the patient has such a problem, and this patient has to be referred to the liaison service. Communications within the care team can be coordinated by the nurse coordinator. Assisting with osteoporosis education, teaching the patient and the attenders, and making the patient understand what medications, when it has to be taken, and scheduling the follow-ups. All of this nitpicks that has to be done, which are essential for the patient for understanding the importance and following, are done by the nurse coordinator. The algorithm as such is identification of the fracture in the emergency, patient evaluation and FFLS referral, follow-up of the patient, which is essential so that we identify what is happening with the patient, the mobility status of the patient, and the overall evaluation of the patient. After the fracture, we call the patient with 2 weeks after the initial injury to OPDs and understand the depth of the patient's injury by identifying what is the vitamin D3 status, what was the DEXA scan, what did the patient actually have osteoporosis, are we identifying it early enough or not. So this is a flow chart which helps us identify, which helps depict whatever I have said in a better manner. Patient comes to an emergency. For any patient, low energy trauma more than 49 years of age, first comes to an orthopedician, then a decision is made whether to do an operative management or conservative management. Then comes the role of the orthopedician and the nursing coordinator. So the patient is given the entire idea of if the patient has to follow up or not, how does she follow up, what all she or he has to get done, and after the OPD, how do they follow up in the referral system, where do they come, what do you have to do, all of those things. And once those things are done, the nursing coordinator helps with the registration, recruitment, blood tests, the DEXA tests, documentation, patient education. The FFLS system, when the patient comes into the system, there are pediatricians and physiotherapists and social workers present in our setup during our fragility clinic, which actually happens on Fridays in the morning. And it helps the patient to follow up in a very simple system and not to run around into 10 places for the same. And the orthopedician, us, we help with devising the treatment plan, with drug prescription and the fracture care that has to be done. So I will not touch upon this because my respected colleague, the geriatric doctor, will be teaching us on how they are planning on giving the medications, but I give a broad idea of like after the DEXA scan is done and the blood test is done, we start anti-osteoporotic medications based on the WHO criteria of any patient who is having less than 2.5. We consider it as increased fracture risk, and appropriately we start the patient on an anabolic agent or an anti-resorptive agent, and the patient is further followed up on 1, 3, 6 months and at 1 year. So all of these things that I've said, we have converted them into a performer. So the FNSL model has a dedicated nursing coordinator. It has to have a very good record keeping system. There is a standardized investigation protocol which is present, and raising awareness of the patient, not just the patient, the attenders, with distribution of pamphlets, brochures, and public lectures showing them videos. The expected outcome is to prevent secondary fractures and improve the quality of life for the patient who have had these fractures, and maybe just that any other patient, maybe they do not get a primary fracture itself, maybe in the family, by educating the attenders. So it's the novelty of the program is it's a first of its kind in India, where we are trying to develop a fragility fracture liaison system. It's all of these modalities that I have described all under one roof, addressing the actual unknown burden that we have in this country, which consists of 1.5 billion people out of the 7.5 billion in the whole world, which as such is a very big chunk. Improving the coordination and communication and care between different departments, and active surveillance of these patients who have had fractures. Now, these are the percentage of hospitals who have implemented a fracture liaison system. And coming to the performer that we are actually using in our hospital, this is a performer that is being implemented in this hospital right now, in trauma center right now, and this is being circulated to AIIMS Jodhpur and AIIMS Rishikesh, and it's a unified system that is being used. So we take a general information of the patient, including all necessary details to contact the patient, even if phone number is lost. We go into weight, height to understand patient's nutrition status, a date of injury, when the X-ray was done, what kind of fracture they had, how the fracture occurred, so that we can prevent such incidences. Like, did they have any pre-fall symptoms? Did they have any vision problems before they fell? Did they used to have any giddiness before they fell? Why did they fall? Such questions are being raised by this simple performer. Now, after this, we go into identifying patients' pre-injury mobility status. Was the patient actually mobile? How well was the patient walking? Was he walking with a walker or a stick or wheelchair? Was the patient wheelchair bound? Some patients do miss that they have had they have had surgeries before, whatever surgeries, maybe some distal end of radius fractures, which was at the age of 50, which they have forgotten about because just 20 years back. So, but asking such questions help us identify maybe the patient have had osteoporosis, but maybe for the past 20 years they were not treated. Now they come with IT fracture. Maybe we should take it more, make them understand the seriousness of it more important. Like, make them understand the seriousness of the matter. And understanding the patient's comorbidities and any contributing factors which have caused the fall, or which might have caused the osteoporosis for the patient, or any other risk factors for the patient. And we also go into depth of what the amount of physical activity the patient had, the vitamin D3 status of the patient in terms of sunlight exposure, any medications the patient was having, how was the management of the fractures that was done for the patient in this setting, and was any anti-osteoporotic medication started or not. All of this are documented in one place, so that we don't have to check different places, different OPD cards for a single patient. And this is a standard investigation. This is a chart for the patient, but this is standard investigation that is done for every patient that comes, and which includes a hormone profile, CBC, RFT, LFT, and along with that X-ray and DEXA scan, so that none of these investigations are missed for any of the patients, and patients are aware what is being done for them. Other than this, we have a follow-up chart where we have even included that if such patients, maybe patients 90-year-old, in case of death has happened, there could be a natural course to a patient. or was it because of any medical illnesses, or was it because of lack of care or lack of mobility? Understanding that and identifying that helps us maybe counsel the patient's attenders better, and we follow up the patient 3 months, 2 to 3 months, 3 to 6 months, and at 1 year. At 1 year, we do DEXA scan. We repeat the DEXA scan to identify if it has the patient's DEXA has actually improved with the treatment or not. And in case of any readmission for the patient during the whole period of the patient's follow-up, any refracture that has happened, there is provision for us to identify why it has happened. Maybe it was because of some medical cause, or maybe it was because of a fracture. But there is provision for us to at least identify if the patient has gotten readmitted, if the patient has been taken care of, etc. Patient education and attender education, like I said again and again, is actually at most important. Not just the patient, even the son of the mother who have had a fracture may be able to comprehend the importance of taking care of her than the actual patient who have had the fracture. So going into depth with this particular scheme helps us reduce the burden overall for the hospital and for the patient as such. So this is a multimodality approach, as I said, and in this multimodality approach, first I would like to invite Dr. Sunil, who is the geriatric medicine SR, who will be indulging us in the role of geriatrician in the management of such practice.
Good afternoon. We'll discuss about the geriatrician role in fracture management. So, why the concept of orthogeriatrics? So, as we know, as decade passes, elderly population proportion is increasing, and most of the hip fractures are more 75 above elderly, and all the elderly people have multiple comorbidities like frailty, sarcopenia, and medical problems like anemia, cardiac disease, hypertension, diabetes, all that, and that leads to more perioperative risk, which leads to prolonged hospitalization and adverse outcomes. So, and as we know, the most common cause of fracture in the elderly is fall, and so its assessment and prevention is essential. And for that, we do CGA, that is comprehensive geriatric assessment. We identify the concomitant disease, psychological problem, and improve the quality of life of the patient. In AIIMS, we follow the AIIMS orthogeriatric model, which is led by orthopedic team, and we provide the consultation-based reactive exercise for the acute fracture management in the form of preoperative, post-operative, and rehab care. And we also provide the OPD services in our setup for the chronic fracture for secondary prevention and primary prevention. These patients have more preoperative complications like pain, volume depletion, electrolyte disbalances, and diabetes, hypertension, comorbidities like anemia. Then we have cardiac failure, heart failure, CKD, CLD, and chest diseases that can exacerbate during admission due to hospital-acquired infection. So here comes the role of geriatrician. We manage the pain. We freeze the anticoagulant during the perioperative period. We provide DVT prophylaxis. We provide care for the electrolyte disbalance and other comorbidities. We also look after the medications that patient is taking, what to take or what not to take during the perioperative period, and all these things are necessary to manage in acute care setting for the clearance of surgery. As we know that guidelines suggest that all the surgeries, all the hip surgeries should be done between 24 to 48 hours to improve the outcomes. We also deal with post-operative complications with the orthopedic team to prevent delirium, to prevent pressure sore and hospital-acquired infection like UTI. So we remove foliage as soon as possible. We also manage the hydration part, anemia, and systemic complication. We reintroduce all the medication as required after the surgery. And we participate with the physiotherapy team for early mobilization and rehab part of the patient. In the OPD services, we work to find out the cause of fracture, to assess the future fracture risk, to prevent the fracture, and we provide nutritional assessment and care and we also do comprehensive geriatric assessment to find out the underlying polypharmacy, incontinence, cognitive impairment, psychological issues like depression, all these things. So as we know, the most common cause is fall. So it is assessment is essential for the, and there are multiple factors that work in the manner of synergistic manner. So we have extrinsic factor, we have intrinsic factor. In intrinsic, we have medical condition like stroke, Parkinson, dementia, incontinence, etc., and medication related to that, which leads to polypharmacy and other drugs like Beer's criteria, one drug like benzodiazepines, SSRI, TCAs, all these things, and psychosocial issues like inactivity, female gender, a patient is living alone, living in the nursing home, elder abuse, elder neglect, all these things. They also have sensory motor problems like muscle weakness, impaired vision, impaired hearing, vestibular problems, cerebral issues, and that leads to impaired balance and poor reaction time, which leads to the fall. For that, we ask all the patient if they had any fall in the past 1 year, and we recommend if they said no fall, we recommend them balance gait and as well as strength training, and we educate well during OPD visit. If the patient came to OPD for one or more fall and seeking medical attention due to fall, we do multifactorial fall risk assessment. In that, we take detailed history of fall, medication history. We ask for the gait. We assess gait and balance. We assess again cognition, visual acuity, lower limb problems, neurological impairment, proprioception problems, and sometimes around 10% of the unwitnessed fall also have syncope. So we also assess patient for reasons of syncope like cardiac issues and orthostatic hypotension, which is very common in elderly. So and accordingly we plan and we reassess periodically patient. Other than that, osteoporosis is also an important factor in this age group. So we recommend balance and muscle strength training to all the patients, those who are visiting our OPD, as well as we do dietitian consultation for calcium rich and protein high protein diet. We supplement vitamin D if a patient is deficient, and we do risk factor assessment again for in that we see if the patient is taking glucocorticoid or not, fall is there or not, if the patient has secondary osteoporosis or not, and like current smoking and excessive alcohol or not. On the basis of that, we decide. And if the patient's this is Canadian guideline, we follow NICE guideline. If the patient's female age is 65 or more, or male more than 70 years, we do BMD and 10-year fracture risk assessment on the basis of Frax tool, and accordingly plan. If the patient has T-score more than -2.5 or risk less than 15%, we do not give pharmacotherapy. If the patient has less than -2.5 T-score or the major risk major fracture risk is more than 15% or hip fracture risk is more than 3%, we give pharmacotherapy to the patient. And we reassess patient three yearly, but it changes on the basis of drug therapy also. So initially we start generally patients on alendronate because this is orally, patient can take orally. If the patient is has contraindication like esophageal disorder, dysphagia, or patient is not able to sit for 30 minutes, in that case we give IV alendronate because that is the only agent that is approved for osteoporosis management in IV form in bisphosphonates. If the bisphosphonates are contraindicated or multiple vertebral fractures are there with T-score less than -2.5, in that case we give teriparatide and at least for 18 months and can go up to 24 months. And followed by that, we give anti-resorptive therapy. Bisphosphonates are generally given. If both are contraindicated, like in the case of CKD, we cannot give both the drugs. In that case, we have to give denosumab. But first, we have to check vitamin D. If the vitamin D is low, in that case, patient can develop severe hypocalcemia. So we have to correct first vitamin D supplementation, and after that we start denosumab. But there is a issue that this is a very costly drug and not available freely. And second issue is that we have to give long uninterrupted therapy, and whenever we stop denosumab, we have to start with alternative therapy. So we give at least 3 years of therapy, and in case of patient develop any fragility fracture in between, or the patient's height is decreasing, in that case we assess with BMD before, like after 1 year we can assess, and after, if the BMD is not increasing, in that case we ask for the if the patient is taking alendronate properly or not, if it is absorbing properly or not. If the patient is on alendronate, we generally shift to alendronate, and if we cannot give, in that case we provide teriparatide. Or in case of multiple non-vertebral fracture, or if the history of vertebral fracture, in that case we give long therapy up to 5 years we generally give, and after that we give drug holiday at least for 3 years, and after that we reassess. And this is not all that we do. We also assess patient in detail about the fall, and that include all the factors that we already discussed. External factor like occupational therapist we don't have in India, but we generally involve the caregiver with us, and we explain them and try to modify as much as possible. Thank you.
Now I'd like to invite Rama to give us the talk on fall prevention for fragility fractures.
Good evening, Dr. Ritika. So my topic is fall prevention. As we all know that prevention is better than cure. So considering this, fall prevention has been adopted as an integral part of FFLS, and in this, the patients and their attendants are educated about the basic techniques of how to prevent falls and avoid fragility fractures. So the first is making your home safer, getting your vision and hearing checked, review your medications with your doctor, and staying active and exercising. So there are certain do's and don'ts of these techniques, like wearing well-fitting non-slippery shoes with flat and low heels, always keeping the floor dry in your home, placing a lamp close to the bed or put up a night light, getting up slowly after sitting or lying down, removing the rugs or carpets, or using non-slippery ones at home, keeping the floor clutter-free from objects, coiling or taping the extension cords and wires next to the wall to prevent tripping, getting the uneven or broken steps of a staircase fixed, improving lighting on staircases for better visibility, use handrails while climbing up and down the staircases, keeping things you often use on lower shelves of the kitchen, and using grab bars to get up from the toilet. Certain rules like do not wear long clothes, they can trap feet and increase the risk of falling when wearing sari. Wrap the sari little high from your feet, and do not bend forward with heavy weight so as to prevent the fracture of the backbone. Using your knees instead for bending at waist. Do not do activities in bending position like putting wet laundry in the dryer, lifting the mattresses to tuck it or to tuck in the sheets. Do not bend to pick up your child. Sit and let the child climb onto your lap. And avoiding crowded public places, as it is easy to get knocked off and fall. And don't be shy asking for seat while traveling in public transport, and not using mobile while walking.
Now I'd like to invite Diksha, our physiotherapist, to give us an insight on how to manage fragility fracture patients.
So, good evening, all of you. Today, we will see the physiotherapy management in case of fragility fracture or osteoporotic patients. So, in case of osteoporotic patients, if there is any fracture which is related to the osteoporosis, first of all, treatment will begin with the goal to reduce the pain. So, to decrease the pain or to reduce the pain, we can use physical agents like heating modalities or ice. Like in case of heating modalities, we can use superficial heating agents like hot packs or deep heating agents like shortwave diathermy, microwave diathermy. And in case of acute pain, we can use cryotherapy to reduce the inflammation and to reduce the pain. We can also use for tender points like ultrasonic massage, which is a form of high frequency currents to reduce the pain at the tender points. Or we can also use the electric currents like medium frequency currents, interferential therapy to reduce the pain and also to strengthen the muscles. Right? So after that, we can move towards the exercises. So these are three forms of exercises we need to do. First of all, strengthening exercises to strengthen the muscle. We have to strengthen the muscle for posture also to maintain the adequate posture, and we can also move with flexibility exercises to increase the flexibility of the muscles so that tight muscles should not produce high impact on the joints, and that can also cause the fractures. And to reduce the risk of falls, we can just proceed with the balance training, because as we know that poor balance can lead to a fall, like basic exercises, standing on one foot, standing with feet together. And we can also proceed with like tandem stepping, static marching, heel raising. And most important thing, we need to just avoid the flexion exercises that can put stress on the, that can put anterior compression forces on the vertebra, which can also lead to the compression fracture. So these are the pictures which are the examples of the chair exercises. A patient can do these exercises at home without any special equipment. So these are the basic exercises, like in this picture, squatting, then wall push-up, sitting row, and these are the balance exercises like heel to toe stance. This is the basically example of tandem standing to maintain the balance and standing on one. So one leg stand, again the form of balance strengthening. So basic exercises like pelvic bridging to increase the strength in hip flexors and lumbar extensors also, and to increase the strength in the hip abductor muscle, which is very important to reduce the risk of falls, as hip abductor muscles are main muscles to maintain the balance and to maintain the balance in pelvis. This is the example of gluteal setting exercises, and again hip abductor setting. So this thing is very important to maintain the posture in case of elderly. So we can just give instruction to the patient that all times try to be tall. And these are the pictures showing the correct lifting posture in first picture, because it can put stress on the vertebra and it can lead to the vertebral fracture. And this picture is showing the correct sleeping posture, like we need to just maintain, put a pillow in between the two legs. And in this picture is showing place a pillow just below your knees to avoid undue pressure on your knee joints, and to maintain the cervical normal cervical lordosis, we need to pillow just under the cervical spine. So these are the basic exercises, retraction exercises to reduce the kyphotic posture in case of elderly people. So exercises to be avoided, that this can put undue pressure on the back, just forward bending. So avoid this forward bending during standing as well as during sitting posture. So thank you so much.
Now I would like to invite Ms. Shalima, who is a dietitian, to make us understand the importance of diet in fragility fracture patients and how to manage it.
Good evening all. As all of you are aware that nutrition plays a very important role in every stage of life, whether it is infancy, whether it is childhood, whether it is adolescent period, whether it is adulthood, or whether it is old age. So we have to take a balanced meal at every stage of life. to fulfill the requirement. This is our dietary intake part, which we take from the patient, detail from the patient, and we fill. After that, we do the calculation of how much calcium he is taking in a weekly, fortnightly, or alternative. These are the sources of calcium: dairy products, herbs and spices, vegetables, green leafy vegetables, and other sources are available. We can add on to these our daily diet pattern so that we can increase the intake of calcium in our diet. Um, Tips: there are some tips to increase the calcium intake without dairy products. We can add herbs, spices, seasonings to our soups, stir fries. We can add collard greens, parsley, turnip greens, mustard. These are the green leafy vegetables which we should add in our daily routine diet. We can spice up our dishes with basil, thyme, oregano, and rosemaries, because all these are rich in vitamin C, iron, and magnesium rich. Eat dark green leafy vegetables in salads with your meals. Add extra veggies to your meals. Use beans, legumes in daily as a part of your daily meals. Add tofu. Add variety of beans in your diets. Start your day with oats instead of calcium. Beyond calcium, other nutrients are also important, like vitamin D, magnesium, vitamin K, vitamin B12, and vitamin C. And all these are nutrients are also necessary for the absorption of calcium in our body. Without these nutrients, we cannot fulfill our uh, absorption of the calcium. Home tips: maintain your weight with normal BMI. Never skip your breakfast. Eat small and frequent meals, at least 6 to 7 meals per day. Eat at least 5 servings of fruits and vegetables. When you feel hungry, eat fruits, nuts, roasted chanas, apricot, figs, and fruits instead of taking burger, chips, junk food, processed food. You have to take these healthy options like nuts and seeds. Take milk with cereals. You can make smoothies with low fat milk, low fat yogurts you can use for making smoothies. You can add nuts to it. You can add green leafy vegetables to fulfill our calcium requirement. Use milk for making atta dough. These makes chapati soft also, and we can fulfill our requirement also. Consume vitamin D fortified oils. Thank you.
I would like to invite Mrs. Sharma sir, our mentor, for management of facilitating participation.
Good afternoon. Actually, we have to agree that more than one third of our ward is now filled with geriatric trauma patients. Suddenly, there has been increase in geriatric trauma patients. So we started thinking about this facility in 2016, but unfortunately, we were not getting any grant. But at that time, Chief sanctioned few staff nurses and few helping hands. So we started, and before COVID only, we could gather data of almost 1,500 patients. But again, there was a problem. It was not coordinated. There was no involvement of other departments, and it was not being done under one roof. So the problem was still there. So this project we got sanctioned, and last year we started recruiting patients. So still you can see total number of patients recruited as 462, and DEXA is then for 237 patients, because the problem is we don't have DEXA in trauma center. So we send the patients to main center, and most of the patients, they don't want DEXA when they are fine. They say we are fine. Why do you want another further investigation? Because even getting a DEXA here, it's a full day problem for the patient. So then we started talking to, in spite of it being free, Dr. Khargawat has done all the forms, they are free of cost, but still patients, we are losing patients, they are not getting DEXA. And DEXA is important. It's not for therapeutic part, but it's important for prognostic part also. You get DEXA today, you put the patient on treatment, and you don't know what exactly is happening. Patient is gaining any benefit, patient is not gaining, you want to switch to other therapy. So that's why this is something very important for the patient. And most of these patients who get DEXA and who are compliant, they are put on treatment. So total, obviously males, they are, in this data, 280 males and 146 females, and 50 to 60 age group is more 146 patients. And even we get around 100 years of patients also. I think we have operated few patients who are more than 100 years, but fracture neck femur, obviously surgery needed to be done.
So most of the patients now they are put on anti-osteoporotic management, and so many patients we are able to get DEXA scans in main hospital. But soon, I think by next year we are going to get DEXA in trauma center, so things are going to get easier. So follow-up 230 patients, they already had 3-month follow finished and 6-month follow. You can see mortality. We came to know that there is mortality like 2016 we started when Santosh Nath came and he asked us how many patients died, and we had no data as such. Then we started looking at the data, at 17% of our patients died, and we were not aware of exact number of the patients who died. So there is a need of such services which at least look at all the data, how many patients are being treated and how many patients are getting benefit. So hindrances, there were challenges. Most of these challenges we are trying to, and we have tried to sort of rectify. DEXA scan accessibility, we are going to look at it, and maybe next year we are going to get DEXA. Rural, urban, most of our population still they come from rural background. It's very difficult for them to call back again and again for follow up. So this is the problem we face. That time we have a coordinator which keeps calling them and which keeps talking to them, because everyone has got now phone and a very good mobile phone and WhatsApp and everything. So they keep talking. Government, there is a program on breast cancer. There is a program on cardiac, but there is no as such nationalized programs on osteoporosis. I'm not aware of any program run by central government on osteoporosis. So they are not at all. I think that still there is less awareness. And interdepartmental communication. This is a problem. This has remained a problem. This will be a problem, but we are trying to talk to. We talk to geriatric medicine people, cardio. I think daily, every week, we keep talking to them. We keep calling them, so that at least once patient with hip fracture gets admitted, within 1 day or 2 days, they come and they at least evaluate the patient and try to make the patient fit for surgery, early surgery. So this is the first service of its kind, and a high rate of diagnosis and treatment. What exactly we have achieved and target is there's lower rate of loss of follow-up, and it's a multidisciplinary approach. It is going to be cost effective, and you don't get a patient who will come back with another fracture. Obviously, cost effectivity will be there and uniformity in, and there will be data for epidemiological purpose. The target is only once. Patient comes with fracture, and then patient comes back after 1 year with another fracture, and patient, because they don't know anything about what exactly how they have to prevent further fracture. So this facility definitely is going to sort of create that awareness, do a multidisciplinary approach, so that patients they don't come back with the same kind of fall, same kind of fractures, and they are not on any treatment for their bone loss. So this is the way forward. In other university hospitals, we have already included 2 major hospitals in Rishikesh and in Jodhpur, and they have like data they have not shared, but they have recruited 12 patients. We have already recruited around 500 patients because they started a bit late from us. So surgery protocol is very clear. Surgery within 36 hours we try to do. Physio, the patient is operated by evening or next day. Physios they come and they start their physio, their diet workup, and if they need other department workup or geriatric work, that is done as early as possible. So that's all. And acknowledgement, I want Dr. Mishra sir, he was the one who gave us initial staff for starting this, and Dr. Malhotra sir, who talked to geriatric people, and he was the one who, I think almost every day geriatric people, they used to come to hospital and they used to look at all these patients. And Dr. Khadgawat is there in all the osteoporotic projects and all the fragility fracture liaison service projects with us. Thank you. And obviously, thank you, Chief. Only 1 year. No, we are taking other fractures also, but most of the hip fractures are the patients who are getting admitted. So most of the data, 90% of the data is of the patients, mainly the hip fractures which are treated. So we are, because wrist fracture comes to emergency and comes to OPD and then treated on the OPD basis. They are not getting admissions, most of them.
So what is in your data set? Is it tripping or is it so basically these are all fragility factors, because the increasing age osteoporosis. So one of the reasons osteoporosis, and besides that, it's like dementia, osteoarthritis, muscle coordination, all of them combined. The silent problems with osteoporosis, all these problems combine to make the more susceptible. Like we said, in fact, silent factors more than their silent they don't need to issue immobilization. Most of the time, it's just pain. The patients are so it's a silent factor, respiratory factor. But prostate respiratory factor, most patients can do dialysis, we have to get. And sometimes, they put silent factors those cases might happen. But the factors are highlighted because you have to accept that is the reason. But you need to rely time goes on by maybe in the 20, 25 years, we'll capture data. We have almost 20% of the population who are we need to think about something. We started and then we figure those values. This is on the back. In fact, even now, I think even data colleges, almost 50% of practices are not most of the major manufacturers, but they are not $100 less than home. Yet infrastructure is not given, not provide that quality of standard of care increasing. As we progress, as we GDP, as we move towards a developed country, we have to care about the lateral. We have to think about setting up hip fracture or hip fracture. They are only well established in the Western countries. I was training in UK, when I was in UK, in Chart was in UK. We know for sure that the orthopedic trauma, almost 70 to 80% of orthopedic trauma is actually not fracture. So we are also moving in that direction. Sometimes we catch up with that with the increased availability of this is what.
Actually, I just want to give one comment. Like the question is, it's a very good question. It's a public health question, I would say. Yeah, and out of these cases, I think we have not critically analyzed the cause of fall, but it is like because we sit in OPD, we keep asking the patient.